So we're going to talk a little bit about, as the panel said here, skyrocketing healthcare costs. Having been a long-time healthcare investor and involved in medical devices probably for 20 years on the operating side, I spent a lot of time really focused on, is this going to make a difference clinically, or are we going to save money? Because in the end, that's what the success of a company depends on in the long run. You can fool some of the people some of the time, but in the end, I think it always boils down to, are you making a difference? Because healthcare buyers are some of the more conservative and data-driven people out there. So we've got a great team. We've got Kevin King, who's the CEO of iRhythm. These guys are all very not boastful, so I can do it a little bit for them. Kevin used to be at GE, ran a large imaging division there, then was CEO of Thomson Reuters, a big data company. Was also CEO of Affymetrix, and then we tempted him away to run iRhythm. He can tell you a little bit about that. Duren is probably the, similar to some of the folks here, straight from the Oakland Business School at Berkeley, having worked in a couple of startup companies, that one of which got acquired, right? Mercury? Mercury got acquired, I think, yeah. So some time at IBM and HP, and is now running a startup which is based partly in India, partly here in Sunnyvale. And Todd Parks, not Todd Parks, Chris Parks. Yeah, you're going to be in charge of the ONC soon enough. Chris is from Nashville and was the founder of Change Health. He can tell you a little bit about his story, but just got acquired by a company called MDON and has got very big plans, so you can hear all about that. So why don't we start with you, Kevin? Tell us a little bit about just, iRhythm, how big is it, how much money have you raised, give us some sense of who your investors are, whatever you'd like to tell us.
Hi, I'm Kevin King, CEO of iRhythm Technologies. Our business is a digital health platform that's focused on the advancement of cardiac care. And essentially what we are doing is revolutionizing the future for cardiac rhythm detection. We do this in a solutions way, essentially through a wearable biosensor worn by patients, variety of algorithms and clinical machine learning tools that connect mobily to the cloud and generate reports, arrhythmia reports for a variety of physicians. So iRhythm is a late-stage growth company. We've got about $95 million invested in the company. We have an FDA-cleared solution that's been on the market for about 3 years. Our average growth rate per year is about 60%. We have about 1,000 users in the United States, have done hundreds of thousands of patients, and on the payer side, we have coverage decisions with about 250 million patients out of about 290. So nearly about 9 out of 10 people in the United States have coverage capability for our service.
Hi, everybody. I'm Duren Bhatia. I'm the CEO of Vuix. So Vuix is a healthcare-focused analytics company. So what we've built is a data integration and aggregation platform, and our solution and platform collects data across a variety of data sources in the hospital system. So we sell primarily into providers and large reference labs. So we've been around about 4 years now, and the solution has been in customers' hands about three years or so. Relatively early stage, we've raised about $9 million so far, growing very aggressively, both on the hiring side as well as on the customer side. So over the past 2 years, we've seen 3x growth year over year. I'm really excited about the prospects. So we're really focused on bringing specific vertical solutions, SaaS-based, within verticals in the hospital. So we've got solutions for lab, micro, pathology, pharmacy, et cetera. So 10,000-foot level, that's what we're about.
I'm Christopher Parks, and I'm the founder and chief development officer of Change Healthcare that I started back in 2007 after both my parents passed away within a year of each other. And we started out direct consumer and then went B2B and started with self-insured employers and kind of moved up that food chain from self-insured employers to TPAs to health plans. And now we have 22 Blue Cross Blue Shields across the country and large self-insured employers like Quest Diagnostics or Cargill or blah, blah, blah. Fortunately for my investors, we had a very nice exit, or as Marty would say, this is effing awesome. And were acquired in Thanksgiving by Imdion. Imdion, for those of you who don't know, there's kind of two plumbing systems across the country as it relates to claims processing between providers and plans. And Imdion is one of those two, probably, in my opinion, the better of the two. But they process about $1 trillion worth of spend every year. And my job now, not only as the Chief Development Officer of Change, but also now Senior Vice President of Business Development for Imdion, is to take what we did at Change and implement that enterprise-wide across Imdion and plug into that $1 trillion worth of spend. So needless to say, I'm getting a little bit sleepy, and my wife would like me to go back to work at the post office or retire or do something like that.
Great, thanks. So, there we go. Hopefully we're sort of the second round here. So it's interesting, when we look at companies, for example, with Vuix, we have an investment in a company called Health Catalyst, which sits on top of Epic, for example. Epic, Cerner, the big EMR database companies. Unfortunately, what those companies don't provide is a lot of actionable information. So what Darren is doing and other companies are doing is trying to figure out how to extract that data to then provide dashboards that are actionable, whether it be directly for the physicians or the COO of the hospital, or actually directly informing patients or putting up things like this patient is at risk of sepsis quicker than a physician might diagnose that. So I would say that, without oversimplifying things, two main areas that we're focused on is one, what these two gentlemen doing are really providing transparency through the healthcare system by making data available. What Kevin is doing, and it relates a little bit more to some of the other investments we're doing, are really service-enabled, technology-enabled services, I should say, where what we're trying to do is, I think historically healthcare has been physicians doing sort of a customized diagnosis or customized work, which is not particularly efficient. Can we move those things to become more automated with technology? And can we also move some of that labor to less expensive people, whether that be nurses, cardiac technicians, physician's assistants, to really leverage then all that heavy-duty medical training and analytical perspective that a physician has. So really making the healthcare system more efficient that way. So I'm going to ask each of you, maybe we can do it in reverse order, just to mix things up. Tell us about do you have any hard evidence for how you really are saving money? What impact have you had? And again, a chance to show off.
Well, I'm Southern, so I don't show off. But, wow, that's like the voice of God. So you got to tone me down here a little bit. Cool. So as we started, that was one of the first questions before plans really began to get focused on consumerism and engagement. Everyone said, what's your ROI? And instead of just going with the generic 2-to-1 or 3-to-1 ROI that kind of got made up during the disease management era, we actually, as we're going through and presenting you or your wife or your family member with, hey, here are ways to save, here, you're going to this pharmacy, if you'll go 2 blocks away, you can save $346, let us help you. Or for recurring more than 2 to 3 times a year, kind of non-acute events, we present those ways to save alerts, we do those interventions or target engagement alerts. We track on the back end that claim, so we know through a verified savings, we showed it to you, you clicked on something, we saw that you scheduled something, and on the back end there's a claim that said, yes, you followed through and did what you said you were going to do. So it's actually a super hard, tangible evidence. Ironically, I would say this though, now that we're moving into this retailization of healthcare, that's important, but that, ROI is almost table stakes. And what a lot on the plan and self-insured employer side of things are grappling with is, I've got all of these vendors, I have all these partners, I have all these tools. I know that what I'm spending money on, people are not using, or I don't know what they're using. Help me get out of complexity and into simplicity and get people engaged. Unfortunately, engagement is one of those words like quality. You only know it when you see it. It's very hard to define. And that doesn't mean just registering. So I think that's kind of the next conundrum over the next couple of years, is helping to grapple and be able to define what the heck is engagement.
We'll talk about that a little bit afterwards, because I think that's going to be very interesting just to talk through the different stakeholders. But for the let's say the employers primarily are buying the solution, right?
So employers and plans.
Okay. And what do you think they're saving? Do you have a perspective on that?
Yeah.
Well, this thing is on and off, so.
That's right. So, what I can say, going back to the cliche, is they're seeing typically 3-to-1 ROI on their investment. But then it's on this initial spike within the first year. It dips a little bit to 2-to-1, and then it begins to take off thereafter.
Great. So you're changing behavior.
Yeah, I mean, the funny thing is, again, if there are clinicians here, they know that it's not the big things that make a difference, it's the small things. So what we typically see is when we help you save $25, $50, $100 on something that's small, like a prescription, it's easy, it's a commodity. Oh my gosh, they said I could do it, I did it, that was easy, right? The small things beget the large things. And what we see consistently over the course of a year, we touch about 75% of a population over the course of the year, because we do medical, dental, vision, and pharma claims. People that get a ways to save alert and act on it, which is more than 60%, they're 6 times more likely to come in proactively on the bigger dollar items and begin to look it up. And common sense would say, geez, if they help me do some of these small things, when it's time for a bigger spend item, you've got a greater, larger deductible. It worked on the small things. I wonder if this works on the big things.
I think that's one of the central things we see too. We all experience this, is changing behavior is the hardest thing to do. It's not just data. It's changing behavior that's just hard, grooved.
Yeah.
So that's the biggest challenge, I think, in these, taking on skyrocketing costs. Darren, why don't you give us a perspective on what you're doing at Vuix?
So, just like you said, change in behavior is really critical, right? So I like to say that you can have as much data as you want and look at data until you're blue in the face, but what are you going to do with it, right? That's really the question to be answered, and that's what we're really focused on, enabling our customers that are large hospital systems and large reference labs in making decisions based on this data that we're providing to them. So historically, they've received data in primitive ways, with what I like to call reporting, but what we're trying to do is put data in front of them at the point in time they need to make a decision. So, from an ROI perspective, I guess, just to give you a couple of examples, one of our large customers is a large reference lab, and they grew by acquisition. So they have about 4 or 5 different systems for their core transactional processes. And you sort of go into these institutions that are large companies and have them answer simple questions like, well, how many tests did you do last year? And that's a challenge, because they got to go to 5 different systems to answer these questions, right? So one of the ways we helped them was with test menu selection. So they were doing these 2 tests, or EIA and PCR. I don't want to get to too much technical detail here, but EIA is not very robust, and it has to be done, iteratively many times. So although it's very inexpensive, a PCR is a more expensive test. So by putting together their reimbursement and clinical data across a variety of these systems, we were able to show them very quickly, well, you have enough volume to just move to PCR, and that would be financially beneficial to you. So that's just one example. Right there, just that one example was 4-to-1 ROI for that particular customer. Regulatory requirements, providing data to payers for calculation of HEDIS, quality measures, et cetera. Payers are taking their business away from these institutions now if they can't provide this information, because they have they have the requirement downstream to publish this information as well. So one customer told us that being able to provide this information was $6 million worth of business per year for them. So we're really focused on putting our data in the hands of these administrators at the point in time where they can use them, right? We're not about providing yet another dozen reports in their inboxes, which nobody really looks at. We want to be part of their workflow, and that's what we're really focused on.
Thanks, Darren.
Make sure your microphone is on. Make sure it's not on mute. Turn your microphone on, sir.
No, it is on. It is on. No, it's on. For our business, cardiac arrhythmia symptoms occur in about 25 to 30 million people in the United States each year. And so largely prevalent condition and very highly important. For many patients, if left undiagnosed, they're at a 5 times risk of sudden death or stroke. So our service is all about helping to figure out which patients have arrhythmias, what types of arrhythmias they have, and whether or not they need to be treated. So we have 3 major peer-reviewed publications that support our cost effectiveness. First one is in normal patients. So a vast majority of patients show up in the emergency room with symptoms of palpitations, dizziness, anxiety, and so forth. And a very large study that we did across 3 centers, Scripps Clinic, Scott and White, and Stanford, showed that about 60% of patients actually don't have arrhythmias. And our test takes 14 days. Patients wear the wearable device for a 2-week period of time. And so the predictive value of a 14-day negative is very, very high. And we've shown that these patients don't come back to the emergency room and they're not admitted. Second study we've done is in a group of patients that have atrial fibrillation. Atrial fibrillation, as I said, can be a life-threatening and costly occurrence. The cost of managing patients with atrial fibrillation in the U.S. is estimated to be $2.6 billion for the first year for Medicare patients. And atrial fibrillation patients are 4 times as likely to be in the hospital, have hospitalization rates 4 times normal. So the study we did was against the gold standard, and we showed that we had higher sensitivity and specificity, but more importantly that we changed medical decision-making in about 30% of the time. 28% of patients had a change in therapy related to drug therapy, procedures, and so forth. And then today we announced or had a press release on a economic cost-effectiveness study where we mined a large data set from Medicare. There's a file that Medicare releases each year called a standard analytical file. It's about 5% of patients. And here we followed the journey of patients through their initial diagnosis all the way through workup with a gold standard, which is a Holter monitor, and then subsequently compared it to our solution. And in essence, we have the highest value, lowest cost offering compared to a gold standard that's been around for about 30 years. And that publication is out, and that was done on about 2.5 million patients as a retrospective study.
Great. You can hold on to it. Yeah. So, all right. Is that better? What was very interesting at iRhythm, just to build a little bit on what Kevin was talking about, was the company's original innovation was a patch. It was a comfortable, wearable patch as opposed to a Holter monitor where you've got multiple leads, uncomfortable, and as a result, people don't really tolerate a Holter monitor more than 24, 48 hours. They just hate it. And so I wasn't there as part of the company, but 7, 8 years ago, that was the original innovation. And the thought was, well, this is just going to be better than a Holter monitor. The company went through a lot of difficult work in terms of showing not only that because you could wear this more comfortably now for 14 days, you could collect, again, if you have sort of intermittent problems, you'd much rather collect that data for 14 days. But now you've got a data problem because you've got literally millions of heartbeats to look at, and there's no way the cardiologist can read it. So then the company had to invest in automation and computers, computing power. And then I'd say that it would be interesting to hear from both of you, convincing a payer now to pay for something where, hey, I could just do a Holter monitor study for $100, or an EIA, ELISA test for $50 or something, and then going to a PCR where you might be running $300, $400. convincing the folks in that whole value chain to change behavior, I think, is a tough part. So can we talk a little bit about that, Kevin? Just, what you've had to do, what surprised you over the last couple of years?
Sure. We think about three stakeholders in our business: patients, providers, physicians being pretty close to the same, and then payers. And our value proposition is really intuitive to physicians. They essentially get it. The payer community has really been a challenge to work with. And I think for appropriate reasons. There's a large proliferation of technology. Tests tend to be additive, and prices are escalating. So working with payers in the United States, challenge, we're not a single health system. So we've got essentially 2,000 payers to deal with. Most of the criteria that they have for decision-making for coverage and payment is not widely known. In essence, we're dealing with peer-reviewed publications, physician advocacy groups, patient advocacy groups, and it takes a large investment to get in front of these folks and to get coverage and reimbursement decisions without question.
Since we're sitting in the Kaiser building, was it easier to go to an accountable care organization?
Kaiser was surprisingly quite easy relative to others. I mean, the value proposition that we have of high value, low cost really resonates well with folks that are focused more on value-directed health. But the vast majority of healthcare is still fee-for-service. And, the incentives aren't necessarily aligned. And in the Kaiser situation, we are in all 36 Kaiser hospitals. It's one of our larger accounts, if you will. And it's used as a frontline test. And we really believe, and I think they believe as well, that it's helping them to save money.
That's great. Thank you. Darren.
We've made the conscious decision to focus primarily on providers. We feel like there's a lot of value there, and that's our primary buyer, if you will. But the data that we collect secondarily gets provided to patients as well as payers. So what we're doing for providers by integrating data across these transactional systems, they find a lot of use cases in providing this data back to payers, like I mentioned, for HEDIS quality measures, or we have customers now providing or using our data platform to populate mobile apps that they've developed to publish test results directly to physicians and patients. But we've focused primarily on providers because we feel like they have a large number of use cases, a large number of challenges that we can help them address, and frankly, we're too small to be focusing on payers as well. And like you said, they're challenging to deal with. So that's kind of what we've been surprised with, where originally we wanted to just provide use cases for providers, but now they're using the same data and publishing it across the ecosystem to patients and physicians and payers, because we've done the dirty work of putting the data together, and it has a lot of use cases outside of what we sell directly, but our customers are using those data sets to address these use cases across patients and payers.
Did you have interactions between, say, a provider, as in the institution, when you shifted from the EIA to the PCR, the genetic test instead of an antibody test, higher cost, higher precision? Did you get pushback from any particular group?
Yeah, so it's always challenging to make that switch, I guess, for these organizations, but it has to be data driven. That's what we're about. The way we positioned it was, that's why you bought Vuix, right? To help you make these decisions, and the data speaks for itself. And it wasn't easy by any means for them to convince them to make this change, but eventually they did it, and it took a few months for them to get to that point. And obviously there has to be a lot of buy-in because there's a lot of stakeholders in these organizations. So that has been changing behavior. Obviously, is a big challenge. Like I was saying, the data, I guess, from the technology perspective, that from our perspective, that's what we know. That's the easy part. But how do you get them to use the data? That's what we're really focused on.
Great. Can you tell us a little bit about the patient side, Chris? You know this intimately now on the what employees do and what it takes to change behavior there. What can you tell us?
I think that the next 5 years, there's going to be a lot of data, and there's going to be very little information. And as we begin to migrate into what is useful information, I think this really, I don't like the word engagement because it's just become over cliched. But what I do know, and what probably we all have experienced is you have so little time and have to make so many decisions and really don't have the attention. I mean, who here really wants to be a healthcare consumer? Who here is itching every day and waking up every morning praying that they can be a healthcare consumer? None of us. And so how do you take this complexity and come up with discrete, as you described it, that was kind of our rule of thumb. How do you get information that is relevant, easy to understand, and actionable? And if you can have those three things, typically, as proven out by several different Hogg and some of the others, small bite-sized chunks of actionable milestones are the things that people will get done, either get a reward or reap the benefit and become much more open to taking incremental steps. It's like smoking cessation and other things. I mean, it does take a village in some things, especially around consumerism, and maybe that village driver is finance and the money coming out of your wallet. Yeah. But ultimately, the surprising thing is it's not hard, it's not complicated, it's just figuring out how to take this complexity and making it easy to give those small bite-sized chunks that are accomplishable.
And did you get the employers to, or payers as the case may be, to then did they need to put incentives in place to shift people's behavior, or was it just, it's fine, look, I'm on a high deductible plan, so I'll just try to save some money?
So two quick tidbits. One, everything we've done with those great results is with zippity-doo-dah, no incentives. Wow. All right? So you don't have to pay. Paying someone to do something is a very short-lived mechanism. Yeah. It doesn't hurt to grease the skids, but it's very short-lived. I think, as you contemplate how you go forward without incentives, how do you just do something recognizing that people are not motivated to make a change? People don't change because they want to change; they change because they have to. So in those moments, how do you make it easy to understand, relevant, actionable? And when you present those things, employers stopped focusing on, again, everyone would love to save $100,000 on open heart surgery, right? Centers of excellence or whatever that big savings is. But that's not a sustainable behavior change. So what we've seen over the past 4 years are employers beginning to say, yeah, I've got all these vendors, I'm not getting the results, but you seem to keep on causing these small actions, and more people are coming on, more people are coming back. So small things benefit to larger savings down the road.
That's great. I think the experience is similar with telemedicine.
Right.
Which is people, boy, I have my doctor that I trust. I think the experience has been once you've done your first telemedicine call, you're much more likely to go back for a second one.
Yeah.
Step by step. So just, I know there's Nina Kjellsen's probably in the audience here somewhere, who's an investor in WellTalk, which is sort of trying to do, I think, something similar. But can you tell us a little bit, just in the closing moments here, about how would you distinguish what you're going to be doing at Emdion from, say, some of the other engagement platforms?
Oh man, I'm going to crush everyone. No, so look, we've been very lucky, and timing is everything, right? And we've been very fortunate that we've had great partners, great customers, and people that understand it is the small things that add up to the big things, and that plan sponsors care about engagement or getting people to do things. Now I have the benefit of an entity, a network that spans across pharmacies, 450 labs, is in tens of thousands of pharmacies, processes 70% of the nation's EOBs and statements, which actually is ridiculously scary that we have that much paper. The thing that I've been charged with is how do you take that engagement, that simplicity, and integrate it across that $1 trillion of spend? How does Change Healthcare, Emdion, make it so that when you go fill a prescription, as it's being filled, I described this earlier, you get a text message that says, hey, don't forget about X. The pharmacist looking at the screen while they're filling it gets the same or a similar message, and something gets, this is again sad, the fax gets printed out and it gets stapled to your prescription bag, right? Additionally, how do we integrate in with those really lame, useless EOBs and make them actionable? Be they savings, automated payment. So we're going to shrink the gap to point of action or point of decision and begin integrating and automating payments, decision-making, savings, and communication all the way into the provider also.
That's a big vision. That's
I know I got to
fantastic.
do that this year, so.
So maybe 15 seconds from you, or 30, Darren and Kevin, vision for the company?
From our perspective, like I was saying, our vision is to put data in the hands of the users at the point in time when they need it, right? So our vision is focused explicitly on getting into the customer's workflow, right? You know, taking it to one extreme, we want to be the analytics platform that nobody really needs to log into even because the data is already present by alerts or as part of their EMR systems or as part of their CRM systems. So that's what we're focused on, exposing our analytics across the systems that these administrators are on a day-to-day basis, and they don't necessarily need to go run reports, which is what they've had to do in the past.
Great. Thank you. Kevin?
Look, I would say for iRhythm, it's about taking this revolution to its completion and really making it a win for patients, payers, and providers. And from our perspective, if all three of those stakeholders don't feel the benefits, we won't be successful. And that's the vision we have, to make sure that everyone is a winner in that.
Well, thank you to all the panelists. We're going to go backstage and drink our bottles of wine, I guess. Thank you all. Bye-bye.